Hello everyone, and welcome to this AHP webinar on Public Health Back to Basics. My name is Linda Hindle and I am one of the Deputy Chief Allied Health Professions Officers, and I'm based in the Office for Health Improvement and Disparities. So this is the first of two connected webinars which aim to provide a recap around public health prevention and tackling health inequalities, why it's important, what our role is as allied health professionals, and some of the tools and resources that are available to help you. Over the last 8 years, allied health professionals have become recognised as an integral part of the public health workforce. We've raised our profile, we've increased our skills, our knowledge and our commitment to the public health and prevention agenda. We've developed our strategic positioning in this space, and we've demonstrated our impact. So lots has happened, but clearly there is still a lot more to do. The COVID pandemic has really shone a light on the health inequalities and disparities within society, and improvements in life expectancy are slowing down. So lots more for us to do. And so it's because of that we wanted to take this opportunity to provide a refresh of some of the fundamentals around public health and what it means for us in our roles as allied health professionals. So in this session today, we're joined by three really great speakers who are going to take us through the first part of this journey. So we will have Dr. Alex McNamara, who is a Public Health Registrar, currently on placement with me in the Department of Health and Social Care. And then we've got, sorry, Alex is going to talk to us about, I suppose, the health of the nation as is at the moment, and why we all have a role in improving health and well-being. Then we've got Kanar Ahmed, who is the AHP Public Health Clinical Advisor in OHID. So she's going to talk about our current AHP Public Health Strategic Framework and what our role is, and the commitments that we've made as a collective of AHP professions. And then finally, our last speaker today is Kelly Hullhouse, who is a physiotherapist from East Lancs Hospitals NHS Trust, but also has been one of the population health fellows in Health Education England, and she did a lot of work on the development of my role in tackling health inequality as a framework for AHP professions, which was published last year by the King's Fund. So she's going to talk us through that and what it means for us. And as I said, then the next webinar will focus a little bit more on some of the tools. So we're going to have our presentations running until about 12:45, and then we will have time for questions from you. So please, as we're going along, be thinking about questions and post them in the chat. If we can do some of the questions as we go along, we will, but otherwise we'll have that conversation at the end. So as I say, thank you for joining, and I'm going to hand over now to Alex.
Thanks ever so much, Linda. That's brilliant. So if we could move to the next slide, just for my title slide, if that's okay. So as Linda said, my name's Alex McNamara and I work as a Public Health Registrar. And today I'm going to be speaking to you about the health of the nation and really why we all have a role in improving the nation's health. So if we could move to the next slide, Trudy, please. I'll just start with a brief outline of what I'll talk about. So I'm going to start with an introduction to what public health is. A lot of the things that we're going to talk about are branded or labelled as public health. So I think it's always helpful to just start at the very beginning, and that fits in with our back to basics theme of the webinar today. I'm then going to go on to talk about the health of the nation currently, thinking about what the key issues are, and then before talking about factors that we know can influence health. I'm going to then hopefully finish off on a more positive note by highlighting some of the opportunities that there are to really make a difference, and then end on some key messages. So if we could move to the next slide, please, Trudy, and one more if that's okay. So starting with the definition of public health. So the Faculty of Public Health define public health as the science and art of preventing disease, prolonging life, and promoting health and well-being through the organised efforts of society. So just to sort of unpick a little bit about what that means and pick up on a few elements within that definition. So the first thing here that always strikes me is, I suppose, that combination of prevention and that in amongst aspects such as prolonging life, and that traditional aspect of healthcare, you know, prolonging life and promoting health and well-being. And it also mentions specifically the organised efforts of society. And I think that's really helpful in demonstrating that actually there is this need for really broad action across a range of areas to really make a difference to health and improve health. So if we can move to the next slide and think a little bit more about what that means in practice. So this is one way of looking at public health as maybe an upstream or downstream approach. And this is actually the way someone initially explained public health to me when I was first interested in it as a specialty. And apologies if many of you have had this before, but I've found it a really helpful way of looking at public health. So you can see on the picture here that at the very bottom, there's an individual who's fallen into a stream, and you can see that there are some people doing some incredible work, saving lives by pulling these individuals out. But if we look further along, we can see that more and more people have fallen into that stream. So while there's these incredible efforts that are absolutely needed in pulling these individuals out once they've fallen in, what's really clear is that there's actually a crucial role in going further upstream to understand why people have fallen in the first place, and also to put measures in place to prevent them from falling in. So thinking about what that does, it not only saves lives and prevent harm in those that would have fallen in, but it also frees up those individuals that are busy working hard down that stream to do other work. Now, I found this analogy absolutely brilliant, but reflecting back, this was first really described to me as this is what public health specialists do, when really that doesn't reflect the much wider public health force and the fact that this can really apply to many others, and especially professionals like yourselves with such important roles. So moving slightly away from this analogy of the stream, thinking about what public health approaches means and includes, is that it considers the importance of prevention. It's that age-old prevention is better than cure, and really focuses in on that. It tries to incorporate evidence-based approaches to focus on what really works. It looks at that bigger picture of population health, in that, you know, going back to that example, thinking not just about the individual in front of you, but further up the stream, that bigger picture and what we need to do. And it also considers wider determinants of health and recognises the need for broader thinking and working in partnership. And I'll go on to talk about what some of those concepts mean, especially around this wider determinants a bit later on. But I think before we can apply these approaches, it's really important to have an understanding of the current health of the nation and think about what those challenges might be. So if we could move to the next slide, and then one more, please, Judy, if that's okay. So I've mentioned within that definition of public health that one of these aspects was related to prolonging life. So starting by looking at life expectancy, we can see that actually if we look over a long period of time, there's been a really, really positive improvement in life expectancy. And we think this is really due to improvements in health for both the younger and older populations. So that's one really positive aspect that we can see as a change in population health over time. However, if we move to the next slide, we can see that there are these stark differences in both life expectancy and healthy life expectancy relating to deprivation. So you can see there in the blue, that's the life expectancy. So in the blue is the healthy life expectancy, and including the grey in the top is life expectancy overall. And you can see that, you know, there are these really unacceptable differences between how long people live and how long they live healthy lives, depending on you know, their levels of deprivation. And if we move to the next slide, if we actually look at recent years, I think Linda alluded to this in her introduction, and we can see that improvements in life expectancy and mortality rates have actually slowed down. And we know that in some parts of the UK, life expectancy is actually falling at the minute. So if we move on to the next slide, we've spoken, we need to also think about why people are dying. So we need to think about the leading causes of death in England. We've spoken about these mortality rates, so it's really important to understand what these causes of mortality are. So these are some data from the Office for National Statistics, and you can see in the graph on the right that they're taken from 5-year averages, so that's in the lighter blue. So those 5-year averages don't yet include COVID-19, but if we take just those data from the 5-year average, we can see that the top causes include dementia, heart and lung disease, respiratory infections, stroke, and cancers. So why is this important? And if we move on to the next slide, we can see that if we look at numbers from 2019, the data showed that almost a quarter of these deaths are considered avoidable. Now, this could mean that they're related to preventable causes, or there could have been cases where intervention or treatment might have prevented death. And I think it's really staggering that it was almost a quarter of these where there was opportunity to prevent or intervene in these cases. And the majority of these are linked to cancers, heart disease, respiratory disease, and drug and alcohol use. And if we look at the graph on the right, we can see that, again, there are these really significant differences of preventable deaths when we break these down by levels of deprivation. And we can clearly see that those experiencing higher levels of deprivation are at a much greater risk of preventable death. I think it's also important just at this point to recognise that there are other forms of health inequalities. There are lots of different population groups who will face different kinds of inequalities in different outcomes, and that these may be linked to deprivation or maybe linked to other factors. But I just felt this is one really important example just to illustrate some of these inequalities. And it can sometimes be a lot of graphs and data to look at, but I think just that visual reminder of what the differences are, I found, I suppose, really quite powerful. So if we could move to the next slide. I've mentioned before that the concept of public health, it's not just about prolonging life, it's about promoting health and well-being. So I think it's also really, really important to understand the leading causes of morbidity or poor health or disability. And looking at some of these top causes, these include musculoskeletal disorders, mental health or substance misuse disorders, other non-communicable or non-infectious diseases, so for example, skin conditions or sense organ diseases such as those affecting sight or hearing. And if we move on to the next slide, what we can actually also do is see that there is an impact of individual risk factors on morbidity, and these can be estimated. And we can actually see that things like high BMI, smoking, high blood glucose, drug use, high blood pressure, and lots of different dietary factors can actually all contribute to the number of years lived with disability. So while I think we can probably all from our own experience think about the impact of risk factors on those individual diseases, for example, the impact on musculoskeletal health from some of these risk factors, I think again, I found this really interesting actually to be able to break that down. But I think what we need to also think about, it's not necessarily just about individual risk factors, and there are much broader factors to consider. So this leads me really nicely into thinking about what factors really do affect our health, in addition to those individual risk factors that we've seen on this slide. So if we can move to the next slide. Thanks, Judy, and one more if that's okay. I'm sure a lot of you will be familiar with this image from Dahlgren and Whitehead. I think it usually goes hand in hand with any talk around public health, but it's really, really helpful because what this demonstrates is the fact that there are many factors that can affect or influence health and health outcomes. Now, this goes from individual factors such as age and sex. We know that there are conditions that we'd more commonly see in a younger population compared to an older population. We know that individual lifestyle factors such as smoking can have an impact on health. I think it's also more widely recognised now that social and community networks that we have also have an impact on health and certainly well-being as well. And finally, the general socioeconomic, cultural and environmental factors are really, really important. And these all have the potential to have direct or indirect impacts on health. These might include things like education, housing, working conditions or unemployment, healthcare services, as well as the wider factors that have affected influence those things. And in terms of what impact these wider, or what we call wider determinants of health have, if we move to the next slide, you don't need to read this in detail, but what these pie charts demonstrate is that existing research has shown that socioeconomic factors play a really, really important role in health outcomes. So looking at the two at the top, that section in the purple are these wider determinants, these social and environmental factors. So in addition to the influence of these lifestyle factors or health behaviours as they're called on there, these between them, they have a really big impact on health, and actually more of an impact than healthcare itself. So I think we can appreciate that there are so many different influences on health, and it's such a big picture, and it can sometimes seem really difficult to place our individual roles within such a broad picture. So that's why I just wanted to take a bit of time to think about some of the opportunities and ways that you might be able to make a difference. So if we can move on to the next slide, and one more please, Trudy. So as I'm speaking to you all as allied health professionals, I just thought firstly it was really important to highlight that you're all part of what is the third largest workforce in the NHS. And we know that allied health professionals spend time with millions of people every day. And it's also really important thinking about that broader picture of health, that we know that there are AHPs working out there, not just in the NHS, but working across other sectors such as local government or education, meaning that there are many more opportunities to make a difference. And if we move to the next slide, I just wanted to put in this slide, which is taken from the King's Fund. And this talks about population health. And you might have heard this term population health being used alongside or interchangeably with public health, and it can make it really confusing. Now, the King's Fund describes population health as being able to convey really a way of conceiving health in that broader sense, and states that this includes the whole range of determinants of health and well-being, recognising that many, for example, education, can traditionally be separate from health services. And there's also this idea that population health might be more accessible than public health, because I suppose it's highlighting that it's not just the responsibility of public health professionals. It's they describe it as creating that sense, that collective sense of responsibility across lots of different organisations and individuals. And just to take a moment just to think about what they suggest that means. So this is their model of population health in practice. And the King's Fund suggests that this includes the wider determinants of health alongside health behaviours. It also includes thinking about communities and also integrated health and care. And particularly important is that these should all overlap and be considered together. And I would go on to suggest that as allied health professionals, you have opportunities around each of these. So if we move to the next slide and have a look at what some of these might actually include in practice. Now, I've taken this fantastic diagram, and this is from the UK Allied Health Professions Public Health Strategic Framework. And Kanna's going to speak more about this later on, but I just felt this was really, really helpful because this breaks down examples of where AHPs can have a role in different areas of public health. So this has been broken down, for example, into health protection. So one example about protecting health is preventing infectious disease. Wider determinants we've already spoken about. Health improvement, so promoting good health and well-being, and also population healthcare. So thinking about the quality of healthcare, thinking about early intervention, and relating back to that population health diagram, thinking about integrated healthcare. So, for example, thinking about those wider determinants, you'll see on the top right that these might include thinking about education, housing, or even influencing policy. So these might be directly related to your role. So, for example, the impact of speech and language therapists on having an impact on a child's learning and development. Or it might be indirectly by thinking about the influence of homes on health, and actually recognising that much broader impact on health, and maybe signposting someone to support around housing or an appropriate service. thinking about both health protection and health promotion, there are lots of opportunities to provide advice to patients or service users or the public, whether that could be around immunisation or around lifestyle factors such as smoking. And you'll see the phrase making every contact count under health promotion, and we'll go through some more examples of what that might mean later on. The idea about communities is relevant to both wider determinants and health promotion, whether that be around community development programs or about supporting those more vulnerable communities. And finally, thinking about healthcare. I'm sure many of you will have seen opportunities to work in a more integrated way. Just one example of many might be multidisciplinary teams around frailty. And there are also opportunities around healthcare, such as early intervention or diagnosis, whether that be indirectly by supporting individuals or raising awareness about screening, or maybe directly. And to use one example, a podiatrist might have the opportunity to detect an irregular pulse. And that early detection and diagnosis of atrial fibrillation could have huge impacts on preventing harm to that individual. If we move to the next slide, I've spoken about making every contact count, and this is really about making the most of those encounters with individuals and thinking about how you can think broadly and holistically to promote good health or consider wider determinants or aspects of health. So we've spoken about some examples already, but this might include advice or signposting to services around diet, smoking, alcohol, immunisations, screening, infection prevention. So one example might just be reiterating exclusion advice from work and school if someone has diarrhea and vomiting. And I think that's really helpful actually, because it illustrates different ways in preventing diseases both in the short and long term. There might also be unique opportunities to pick up on early signs of a disease and signposting that person to other healthcare services. And it might be thinking even more broadly about education, employment, housing, finances, or other factors, and just thinking about signposting that individual to services that could have, much broader effects on their health. It can actually be really difficult to sometimes think about this on top of what I completely appreciate are incredibly busy and demanding roles. But I've just reflected that when I used to work in a clinical setting, I can remember lots of examples of when I'd taken the time to think about aspects of health that are outside of the specialty that I was in. And although I didn't know at the time, I'm actually really pleased to have taken those opportunities reflecting back now. And over time, I did get to actually see an impact of having those conversations and asking those questions. And for when it's really easy to think about, will all of these short conversations or bits of advice actually make a difference in population health? I just wanted to, if we could move to the next slide, just share with you this idea about shifting the curve. This suggests that encouraging small change across everyone can actually make a big difference to population health overall. So while it's also still really important to focus on the people at higher risk on that right-hand side of this graph, if we actually just make the effort to shift everybody to a lower risk category, the evidence is that that actually has huge impact on the health of the population. So if we move to the next slide, I fully appreciate that everyone's roles here will be very different, and some of these ideas might resonate and some of them might not. And it can sometimes be difficult to think about this in the context of your own role. So I just wanted to very briefly highlight some of the resources that demonstrate brilliant examples of AHPs really making a difference across different professions and contexts. So for example, case studies on the Royal Society of Public Health website, findings relating to health inequalities, and AHPs having healthy conversations. And if we can move to the next slide, I just wanted to finish by asking some questions that will hopefully make you reflect a little bit. And I don't expect that we'll have the answers to all of these today, but hopefully it'll help you think and take some of this forward. So thinking about who you work with, both in terms of individuals and the wider community, what impact could you have with every interaction? Are there any areas of public health that relate to your role that you could be involved in? So for example, improvement projects. Does policy or strategy need to change to reflect the importance of these aspects such as prevention? And who might need to be influenced to do this? And finally, I recognise that probably many or even all of you incorporate lots of these aspects into your roles already or naturally, even if you wouldn't have labelled it as public health. But it might be worth having a think about what might help you to incorporate these more into your role. And if this is something that you've been thinking about, then there might actually be some more help and resources in the next webinar coming up. And if we can move to the next slide, I just wanted to end on some key messages and one more, thanks Judy. So finally, thinking about population health is relevant to the roles of all healthcare professionals, but especially there are many opportunities for AHPs to think about public health in their roles. And this is from contact with individual service users to influencing other aspects of practice, policy or approaches, even if it's just inspiring a colleague. And finally, I just want to inspire you and reassure you that there is opportunity to make a real difference to population health in your roles. So I hope that's been helpful. And I'd like to next hand over to Kana, who's going to be speaking a little bit more about the framework, strategic framework.
Thank you so much, Alex. So I'll just wait for my title slide to come up. And I'm Kana. I work with Linda at the Office for Health Improvement and Disparities, and I'm a children's dietitian by background. Here we are. So today I'll be spending the next 10 minutes talking about the UK AHP Public Health Strategic Framework. Next slide, please. So Alex described the importance of public health in her presentation, and I'll be looking at how the framework supports AHPs to embed public health into routine practice. And why is this so important for AHPs? Well, as Alex mentioned, we do make up a third of the workforce and we work across the NHS, social care, education. We have over 4 million contacts with service users every week, and we work across the life course. And public health, more than we realise, informs part of our normal assessment and intervention with service users. So the vision for this framework was really for AHPs to continue working to improve the health of the population, and for public health to be recognised as a core element of our role, and ultimately that will help to reduce health inequalities and improve people's health and well-being. And I wanted to kind of point out some of the skills that we have in public health that perhaps we don't always think of. So next slide, please. So before I do that, just wanted to say this framework is available online. Do have a look at it. It sits alongside the AHP's Interaction Framework, the NHS one, and it does follow the initial strategy that ended in 2018. Next slide, please. So I'm not going to go through all of these 4 domains of public health because I think Alex covered that really well, but I just wanted to pick out some of the skills that AHPs have and utilise with regards to these 4 domains. So things like supporting people with financial management. So I know as a dietitian we often talk to people about budgeting with food. We often do things like motivational interviewing. Lots of AHPs have skills in helping people to be more mobile and increase their physical activity and improve quality of life, or supporting resilience and going back to work. We also lead on things like national campaigns for health, and you know, we look at how to improve access to our services and how to catch things early before things develop. So next slide, please. So there are 5 key areas in the framework, and what I'm going to do is give you some examples for each of those 5 key areas, so that you can see the kind of work that's being done to promote public health amongst the AHP community, and also showcase what we're already doing. Next slide, please. So the first area of the framework is developing the AHP workforce, and this is really important because what we want to do is make sure that public health is covered in all AHP pre-registration education, and that is of a high quality. And the second bit of that is that we'll be looking at defined routes for AHPs and AHP support workers to advance their practice in public health. So there's a lot going on to look at how people can do public health as a career or part of their career. So next slide, please. So one example of the work being undertaken for that part of the framework was the we've developed some guidance on embedding public health into the pre-registration curricula for allied health professionals. And in 2015, there was a survey of universities that showed that 50% of AHP courses included curricula information about public health, and only a third reported their content as strong. In 2017, this guidance was released, and in 2018, the survey was repeated, and then it found that 100% of AHP courses then included public health in their curricula, and half reported that content as strong. And last year, the guidance was refreshed, and our target for 2024 is that 90% of universities report their public health content as being strong. Thank you. Next slide, please. And another thing to mention about this undergraduate work is that we're looking to expand public health student placements. So we've looked at understanding the opportunities to do that and the barriers. We've helped develop toolkits for providers, universities and students. We're currently piloting a digital matching tool, and there'll be more information and communications about that coming shortly. Next slide, please. So those are examples with element 1. Element 2 was demonstrating our impact. So first of all, that is advocating for more public health research within the AHP community. And the second is that we ourselves develop, build and share on the evidence base for AHP contribution to public health. So next slide, please. So we undertook a study looking at the key priorities for AHP public health research, and this was published last year. And I just put in bold those the top 3 priorities that AHPs felt were key. So the first was what is the impact of AHP practice in reducing health inequalities? The second was what's our cost and outcome impact of AHP interventions focused on the prevention and early intervention as opposed to just treatment? So how can we capture our outcomes when we do more public health work? And the third is what is the impact of AHPs in improving the population's health? So next slide, please. So one example of where we've progressed those key research priorities was this study that we commissioned and had published last year, which was a rapid review of the impact of allied health professionals on health inequalities. So I won't go through it today. And of course, Kelly will be talking about health inequalities in her talk next. But I do have a look again at that paper. I'm going to be signposting you to our website where we do upload all of our evidence, and you'll find the framework there and other resources as well. But where we've done work to look at some of those public health priorities, it will be uploaded to the website that I'm going to show you a few slides down. Next slide, please. So the third key element of the framework is increasing the profile of the AHP public health role. So that's both increasing awareness of the role of AHPs in public health, both amongst the AHP community and outside of it in the wider kind of health and care space. And secondly, for AHPs to be able to demonstrate their added value to public health. Next slide, please. So one way that we as AHPs can identify what our role is within public health is this fantastic toolkit that we developed not recently, it's been out for a little while now. You may have seen it. It's the Embedding Public Health into Clinical Services e-learning for Health Toolkit. And what it is it takes a quality improvement approach to looking at your service and the way that you can embed public health into the way that your service is designed. And it is really recommended. You can see the evaluation there. Health professionals outside of AHPs use this, and it's a really nice tool, but I'm not going to go through it today because our second webinar in this series will cover this in a bit more detail. Next slide, please. And as I mentioned, this is a website you'll find where we collate all of this information. So if you go onto the Royal Society of Public Health webpage, where you've got the Allied Health Professions Hub, and all of the, the framework, our reports, guidance tools and training, the evidence reviews and research papers that are published are all in here. And I wanted to highlight the case studies tab because this is where AHPs can demonstrate their value to public health. So what we have is a repository of public health projects and examples from AHPs and working in lots of different areas. So you can browse those, and you can also submit a case study if you'd like to. Next slide, please. I'm going to speed up a bit. The fourth area is really that we strengthen our strategic connections and leadership. Next slide, please. And I just wanted to show there we've got lots of partners that we work with and work in, and we are, as AHPs, involved in influencing lots of key stakeholders, and especially with regards to policy and guidance and collaborations. Next slide, please. Kelly's going to be talking about our work with the King's Fund. Next slide, please. And finally, the health and well-being of the workforce is a key priority here. And in 2022, we will be developing a framework for workplace health and workforce health, and the AHP role in promoting that. Next slide, please. And future opportunities and priorities for us are the ongoing health inequalities work, the alignment with the environmental sustainability and greener AHP agenda. We will be releasing some public health examples for each of your professions in 2022. And again, I talked earlier about expanding student practice placements. We're also looking to upskill support workers in public health and to look at the AHP public health leadership within the new ICSs. Next slide, please. If you're interested in more information, please join our community of interest on Twitter at AHPs for Public Health. Next slide, please. Thank you so much for listening. And I'll hand over to Kelly, who's now going to talk about health inequalities.
Thanks, Canna. So, as you've heard, my name's Kelly Hullhouse. I'm a physiotherapist, and I've been specialised in musculoskeletal physio since 2003, and have continued to work in this area since then. But over recent years, I've developed a special interest in all things public health. And as Linda mentioned, over the course of 2020-2021, I completed a secondment with Health Education England as a population health fellow, which enabled me to follow this passion really, and led to my involvement with some of the work around the AHP health inequality framework. Next slide, please, Julie. So in terms of the framework itself, I'll come onto that in a second, but hopefully some of you have seen it already since we launched it in July last year. If you haven't, don't worry, hopefully today will explain a few things and hopefully inspire you to take a deeper dive into it at some point soon. Before I talk more about the framework itself, just a quick bit of background to how its existence came about. So I'm sure everyone will be aware of the concept of health inequalities, but for the avoidance of doubt, health inequalities are systematic, avoidable and unfair differences between populations, within populations, and across social gradients. So these can be unpacked into inequalities in healthcare itself, such as access to healthcare, to treatment, to patient experiences, as well as inequalities in health outcomes, which refers to differences in mortality and morbidity, as we heard discussed earlier. For certain, embedding public health and prevention into the work we do as AHPs in tackling health inequalities is now becoming a more pressing and prominent issue at the forefront of the AHP agenda. mainly due to COVID and the way it's highlighted existing health inequalities. And we've seen this everywhere. We've especially seen it up here in East Lancashire, where I am, which in pockets of this area is in the 20% most deprived areas in the UK. And we've seen how disadvantaged communities have been disproportionately affected by COVID and continue to be. So health inequalities is a massive area to focus on, and because of this, it's quite difficult to see what our role is as individual AHPs, or even within our teams and services in making a difference. It can feel that it's too big a mountain to climb sometimes, and it can occasionally be a preconception that it's not our job, or it's only the role of those colleagues working directly in public health. And we want to dismiss that myth really if we can, because the fact is that health inequalities are everyone's business. They affect everyone, and whatever our role, we can make a difference in several different ways. And the aim of this framework is to help to guide AHPs through that thought process, to demystify and facilitate further discussions around how we as a group of AHPs can impact on health inequalities. As Alex mentioned, as a group of AHPs, we're the third largest workforce in the NHS, so potentially our influence could be absolutely massive in tackling inequalities. And we've seen lots of examples of the fantastic work that AHPs have been doing throughout the pandemic to support people and to support services to overcome COVID. And as we move forward, the challenge is not only to consider our role in minimising health inequalities and preventing any widening of that gap, but it's also to demonstrate the impact that we are having as an AHP body. We know there's lots of work being done, but when you look for the evidence and search the literature, it is quite difficult to find the impact, the direct impact of that AHPs are having on tackling health inequalities. So the framework will hopefully help us to consider these things in more detail, so that we can make a difference in improving population health, and timing wise it arrives at a really good time. That's kind of the background and the intended purpose of the framework and how it's been created. It was commissioned by Public Health England and NHS England and developed by the King's Fund, notably Dirk Dougal and David Buck. But it had the input and representatives of all 14 AHP professional bodies. So it's a real collaborative piece of work which combines expert understanding of population health with the guidance of the advisory group to create, in effect, a one-page framework which is really simple to use and contains many resources and practice examples. Next slide, please. So I think it's important to say that the framework isn't intended to be a teaching tool. It's not intended to tell people what to do or how exactly to tackle health inequalities, but it is designed to stimulate thought and develop conversations and debate about this topic. And it does this by looking at public health and health inequalities through 6 different lenses, which you can see there. So yourself as an individual, the role of caring for patients, your role as part of a team and service, your role and involvement in communities and networks, your role in the wider healthcare system, and your role in the future and nurturing the future. Within each of these sections, the framework encourages us then to think of it from 3 different angles, which are packaged really quite nicely under the headings of awareness, action and advocacy, as you can see in the middle of the diagram. And these themes run throughout the framework. In terms of awareness, it's about what AHPs need to know about health inequalities in relation to those 6 sections. Action refers to what actions we might need to or want to take, and advocacy is about considering your role as an advocate for health inequalities in each of those sections. So I'm conscious of time, but I would like to run through these sections in a little bit more detail, just to sort of demonstrate how the framework can facilitate some thoughts about the role of AHPs in tackling health inequalities at whatever stage of your journey you might be at. Next slide, please, Julie. As I mentioned, the framework encourages all to start at the very beginning with ourselves and thinking about what you need to know about health inequalities and why you want to or need to know this. Why should it be on your radar, which I think is crucial, as it really is the building blocks to anything else that comes after this. So being aware of this is really important. It then enables you to take appropriate action to expand your understanding and knowledge, which might be self-learning, it might be something more formal. And then it encourages you to be confident in being an advocate for public health and what you know about it. So again, this can be something quite small, such as being the voice of public health and health inequalities on everyone's shoulder in meetings, something like that. Next slide, please. Second section, as you might recall, focuses on the patient and care of patients. And again, we look at it through the awareness, action, advocacy approach. So having an awareness of how health inequalities can affect the care of your patients and what are the population health needs of the people you serve. thinking about whether or not the way care is currently delivered meets those needs. And if it doesn't, what action can be taken to address this? Is it through embedding better prevention approaches, better earlier identification opportunities, or longer term support care via signposting to external services, for example, that can help? And in terms of advocacy for the patient, this might be something around sharing best practice that has positively impacted on patient care and contributed to reducing health inequalities. Next slide, please. The third section centres on the role of the team or the service in tackling health inequalities. So again, in terms of awareness, is it something that your team is aware of? Is it a shared focus or priority for your team and service? What action might be appropriate to ensure that it is, and to ensure your service does start to consider this, and to consider whether your service design is meeting the needs and enabling the team to respond to health inequalities, as well as those population health needs? And if it's not, what action needs to be taken to change this? What role can your team play in being the advocates for these population health needs, and what mutual benefits are there likely to be in any service redesign that potentially works differently and brings in different stakeholders, etc. Next slide, please. Next up is the role of communities. It's important and might be useful to be aware of who and what services you're already connected to already, and to be aware of the added value of collaborative service and pathway design, what that can offer. And that can be achieved through sharing examples of best practice across networks. What action can then be taken to strengthen connections and improve any cross-agency working or relationship building, for example, with the aim of improving care at certain hotspots and subsequently improving outcomes for certain population segments with regards to health inequalities? And across these networks, can you be the advocate for the population you serve and contributed to changes in working approaches that might potentially have a positive influence? Next slide, please. We've got two more remaining lenses to consider, and I'll try and be quick. So one of these is the wider healthcare system. The framework points out that every organisation should have a health inequality lead. So simply being aware of who this person is important, and not to mention really useful. And being aware of how health inequalities affect your wider healthcare system is absolutely vital, so you can fully understand the role you play within that system. Next slide, please. And finally, the framework encourages us to think about the future. So there's currently lots of buzz and energy, and rightly so, around workforce diversity, ensuring the workforce is representative and equal for all. In terms of the future, it's really important that action is taken to ensure this happens optimally, and that we take action to ensure that health inequalities remains high on the agenda for the future workforce by embedding it into practice now, and continue to be advocates for this as well for the future workforce. Next slide, please. So that's a quick whistle-stop journey through the AHP Health Inequality Framework, which I hope has been useful and potentially whets your appetite for knowing more. Moving forward, the hope is that this framework will be helpful to AHPs in considering health inequalities in your own practice, but also hopefully encouraging AHPs to encourage their fellow colleagues to consider their practice as well. Within the framework, there's lots of fabulous examples of AHP's work and case studies of tried and tested interventions that are contributing to health inequalities at various points in the healthcare system, which might be a really useful starting point to facilitate ideas, conversations about how you might go approaching this yourself if it's something that is new to you. It's a really good point of reference, really good point for inspiration, for growing your networks, for knowledge, and lots of useful references in there as well, as I said. So I'd encourage everyone to have a look at it when you have time, if you haven't already, of course, and to share it across your teams, your services and your networks as widely as possible. But also thinking it's equally important, if you have used the framework, if you are doing some work that contributes to tackling health inequalities, that you help us to share that work really, and Canna's alluded to how one of the ways that you can do that through sharing some case studies with us as well. And it's just vital that we know that, so that we as a collective group can really develop our skills further, really embed the work that we're doing into practice as business as usual, and tackling health inequalities from whatever profession and whatever role you sit in, so that we can keep this momentum going around population health and contribute to a more equal future for everyone. Thank you very much. I'll hand back to Linda.
Brilliant. I'm just checking that you can all hear me now. Thank you very much to our three speakers. You did very well at sticking to time, and there were excellent presentations. So thank you for those. We've got 10 minutes now for questions, and I know there's a few posted in the chat, and I've had a few others kind of sent directly, so we'll try and get through as many of those as possible. Just quickly before we do though, just there's been a few references to the next webinar, which is on the 7th of April, and that will look at quite a few of the toolkits and resources that are available, specifically All Our Health framework, embedding public health into clinical services, our role in social prescribing and the AHP framework for that, the Everyday Interactions toolkit, which is about how we measure the impact of MEC type conversations, and the links between this work and the greener AHP hub. So those are the things that we're going to focus in a lot more on the next one. So coming to the questions, so I'm going to go to the first question from Emily. So thanks for this question. I'm going to bring this to you, Alex, if that's okay, which is tips about how to get into roles like a public health registrar as an allied health professional.
Yeah, that's a really good question, and it's brilliant to hear about the enthusiasm for public health. That's fantastic. I think firstly to highlight that that's one of the great things about the registrar training scheme is that we have people coming into that training scheme from lots of different backgrounds, which is a real strength. And firstly, I'd say it's just worth finding out a little bit more about the training scheme and what that involves. So there's lots of information on the Faculty of Public Health website. And also, if that is something you're thinking about, it's really helpful to have an understanding of the recruitment as well. I think just that understanding of the processes is helpful just as preparation for anyone who's thinking of applying. I'm based in Yorkshire and the Humber, and I know that if you wanted to have a look, there are some great resources from our open days that are available online just to find out a bit more. They've got examples of people coming into the training scheme from lots of different backgrounds, so that might be helpful to hear about their experiences as well. I think it's really helpful to highlight that as AHPs, you'll be at a great opportunity to think about public health and apply. And if you've got that enthusiasm and can think about that, you know, with your existing experience, that'll be brilliant. That'll be so helpful in applying, thinking about anything you have to do as part of that recruitment, interviews, things like that. So just think about what that means to you in your role and why you want to do it. I think if you can convey that enthusiasm, then that's always a brilliant thing. And just finally as well, just to highlight, there are lots of other opportunities as well. I'm a great advocate for the training scheme. I think it's fantastic. It's the best decision I made moving into public health, but there are other roles such as public health practitioner roles, and obviously there's, as we've heard, there's lots of opportunities to incorporate public health into your own practice as well. So if you're not quite sure how you want to get involved in public health, there are lots of opportunities around that. But I'm also happy to have a chat with anyone about the training scheme as well if they'd like to. That's not a problem.
Fabulous. Thank you very much for that, Alex. Just to say, if anybody is interested in that scheme, it's very competitive to get onto it. And so often people need to apply more than once before they get on, but quite a few AHPs have made it. So if anybody is thinking about it and wants to speak to allied health professionals who've gone down that route, get in touch with me and I can pop you in touch with people. But also we're looking at developing advanced practice routes in public health as well, which would enable you to stay as an allied health professional and specialise in public health. So lots of different routes in. So the next question I'm going to come to you for this one, Kelly, is about how do you access local data, local population health data to look at health inequalities and other public health issues?
Yeah, so there's lots of different ways you can access data, and that probably the simplest and most easiest to access is Fingertips tool, which is available. If you Google Fingertips, it will take you to the website, and it's really useful in terms of breaking down districts, regions, specific information. There's a lot of information on there, so it's just a case of picking out the most pertinent bits to yourself, but it does cover a lot and give you lots of insight. there's other tools as well, but also one of the things that I found most useful in my practice is linking up with our local authority public health teams as well, and really collaborating with them, not only in terms of finding out data, but also that strengthens those connections that we're talking about within the framework that have helped us to really build on that, to develop collaborative service delivery as well to address these. So I'd encourage people to reach out to colleagues in that sense as well.
Brilliant, thank you for that, Kelly. And a really good question that's come in, and I'm going to give it to you, Kanar, is that kind of ongoing challenge of the fact that, you know, we're all busy at the front line firefighting. So how do you find the time to focus on public health and prevention when there's not necessarily any extra resource or extra time?
Yeah, that's a huge challenge, the kind of workforce pressures. I think, first of all, it's important to think that that image that came to mind when you asked that question for me was that stream that Alex showed earlier, the kind of stream and going as upstream as possible with your service. So if you want to make sure that you're doing a bit of public health and intervening early, you're going to actually reduce the workforce pressures in the longer term. So if we take, like, you know, care homes, for example, it's much better that AHPs are involved in preventing problems than when we're involved in the hospital setting trying to deal with those problems. So just a few examples come to mind from the enhanced healthcare and care homes work. You know, physiotherapists going out to care homes and training people on how to prevent falls mean that you need far less physiotherapists in the hospital to actually deal with the rehab from the falls later on. So what you really need is preventing the falls in the first place. You know, dietitians can work in care homes to improve nutrition and prevent dehydration, again by training staff and putting things into place so that people aren't coming in with UTIs and dehydration and malnutrition, which leads to longer hospital stays and not just the need to see dietitians when they come in. Music therapists can help reduce agitation and reduce the need for antipsychotic medications in patients with dementia. You can think of speech and language therapists. There's been lots of work done in Ireland looking at reducing choking in care home settings and other settings, and that again reduces the need for speech and language therapists input later down the line if you can reduce the choking episodes and recognise aspiration as early as possible. So I think the main thing I'm trying to say is making a case for change, speaking to all the people that would be interested in doing that work. So people in your ICS, people in your so integrated care system, talking to your local primary care networks, the people in your community services, hospital services that might be interested in changing the way that you work, but even just trying something out. And the reason I showed you the kind of case study section on our website earlier was because there are so many examples where allied health professionals have taken a public health approach to their services. So you can really just see how you can do it on a small level to start off with and try something out and see if it works. So do have a look at those case studies, because I think you'll find it makes more sense there.
Brilliant. Thank you for that, Kanar, and a really good comment in the chat as well from Lee, who works in secondary mental health and uses that public health approach a lot of the time as part of care in terms of kind of employment, benefit support, physical health, etc., and suggesting that we can learn from that sort of very integrated approach that's used in public health, which is absolutely spot on. So thank you for that. I am really conscious that we're running out of time, so just one quick comment at the end from Helen, and then I'll say some thank yous. So yeah, the advanced clinical practice. Loving the fact that we've mentioned that and recognising that route in advanced practice in primary care and other aspects as well. So how do we submit a case study? If you go onto that website that that Kanar has just mentioned, there is a link there how to submit a case study, and there's something you can click on there with the template and where to send your case study. So what I'd like to do now is just to thank you all for attending. Obviously thank our excellent speakers, Alex, Kanar and Kelly, but also thank Rachel, who pulled together the agenda for the for the webinar and did a lot of the behind the scenes planning in advance, and Magatu and Trudy, who have done the behind the scenes work today, and again promoting the webinar, this one and the next one. So thank you to all of you, and this will be, as Magatu's put in the chat, this will be shared on the NHS Futures AHP pages, and we will also try and see if we can get a copy of this to go on to that RSPH space as well. So thanks everyone for joining, and we look forward to seeing you in 2 weeks' time on the 7th of April for the next webinar. Thank you.